today's forum from 1 to 4 is to educate and inform, but it's also about relationship building and collaboration. So even though my term expires on January 5th and there'll be a new mayor, I'll be the former mayor and I'll be Bob from Brockton, but at the end of the day, we will continue to work together because that's what proved during the pandemic. Although we lost second highest loss of life in the Commonwealth to Chelsea, we lost 549 residents. It would have been drastically higher had we not come together as a whole. Neighborhood Health Center, Good Sam at the time, which is now BMC South, Signature Healthcare. Everybody worked together with the eyes on the prize to make sure that the city of Brockton is healthy. We have to continue that effort right now. Unfortunately, we have the highest uptick in HIV positive cases in the Commonwealth of Massachusetts. We have a lot of people dealing with opioid addiction and challenging sobriety. So today's forum is for us to come together during the holiday season to come up with a plan so that the year 2026 will be better and brighter for each and every one of us and those that we serve. So as mayor, I thank you for being here. Again, I want to thank Doctor and Doctor. I want to thank our partners in the Commonwealth of Massachusetts, DPH. I've been the mayor since January 6th of 2020, 6 weeks before the pandemic. DPH has been nothing but an unbelievable partner. At that time, it was the Baker-Polito administration. Now we have the Healy-Driscoll administration, and everybody works together. So again, 106,000 residents in the fine city of Brockton, but we don't just touch Brockton, we're Brockton and beyond. So God bless each and every one of you. From my family to yours, happy holiday season. If you celebrate Hanukkah, it's coming up, the 14th, and then we have Christmas and Kwanzaa. So let's continue to roll up the sleeves and get the job done. Thank you, everybody.
But we welcome you all here this afternoon to this symposium. I think it's long overdue. We had the last one about 3 years ago, and we have some of the folks who participated in the first one here with us. And so it is a great honor to have you here this afternoon. So we welcome all of you here. We have some data that we're going to share with you. That's the data that we have collected for 5 municipalities: the city of Brockton, the town of Avon, the town of Abington, the town of Stoughton, and the town of Whitman. I am volunteer, the Executive Health Officer for the city of Brockton, and again, it is my great honor to be here with you today.
And as we look at Plymouth Norfolk 5, a shared services arrangement that is not only embracing the future of local public health, but actively building it. Abington, Avon, Brockton, Stoughton, and Whitman should all be incredibly proud of the leadership, collaboration, and commitment you are demonstrating through this work. I have had the distinct pleasure and honor to work with this talented, dedicated group of local public health professionals for several years now, and I continue to be inspired by your ability to rise to the occasion and do unprecedented things in uncertain times to protect the health and well-being of everyone you serve. Now, as we know, Massachusetts has long been a national leader in public health, and thanks to your efforts, we are entering a new era of strength, coordination, and shared success. While our state's 351 local public health jurisdictions have historically faced challenges like limited staffing, inconsistent training opportunities, uneven data systems, today those challenges are being actively addressed, and much of this progress is happening through the Public Health Excellence Grant Program. The PHE grant is equipping communities with the tools and capacity to modernize public health, and the Plymouth Norfolk 5 SSA is an outstanding example of that progress in action. By signing an intermunicipal agreement and sharing staff across Abington, Avon, Brockton, Stoughton, and Whitman, you are demonstrating how collaboration can turn long-standing challenges into real, measurable improvements. For years, many local health departments have struggled to meet all components of the CDC's 10 essential public health services, not because of a lack of dedication, but because they lacked the resources and capacity needed to meet a myriad of demands. Today, with PHE grant support, communities like yours are preparing for and adopting the foundational public health services framework, ensuring consistent, high-quality public health protection for residents across all 5 towns. This was once aspirational, and now it's achievable, and you're proving that every day. The success of the Plymouth Norfolk 5 highlights one of the greatest strengths of the PHE program, which is cross-jurisdictional sharing of services. No longer are Abington, Avon, Brockton, Stoughton and Whitman working in isolation. You're pooling expertise, coordinating inspections, supporting shared specialists, and delivering services more efficiently and more effectively across all member communities. We have long known that shared models improve outcomes, staffing stability, and compliance with state and federal mandates. Now, because of your work, we are seeing those benefits become reality on the ground. Your progress is also strengthening one of the most essential pillars of present-day public health, data, just like this community health needs assessment we went over, which was incredible. Historically, inconsistent reporting systems have made it difficult to track trends or plan for future needs. But the PN5 is building the shared infrastructure needed for consistent, high-quality data collection. Data that drives smarter decisions, strengthens performance, and supports a stronger response to emerging challenges. And with coordinated staffing and training, your workforce is becoming stronger, more connected, and better prepared than ever. The PHE grant is also helping to address long-standing funding inequities that have made it difficult for some Massachusetts towns to keep pace with public health mandates. By supporting shared services, the grant is ensuring that every dollar invested, whether in Abington, Avon, Brockton, Stoughton, or Whitman, goes further, reaches more people, and has a greater impact. This is what sustainable public health investment looks like. What we are witnessing through the PN5 is the beginning of a long-term transformation, and that transformation is being driven by your willingness to collaborate, innovate, and push towards higher standards. With ongoing engagement and partnership and continued support from the PHE program, we're building a stronger, more equitable public health system for every resident in your 5 communities. Most importantly, your work demonstrates a powerful truth. When municipalities join together, sharing staff, sharing ideas, and sharing responsibility, public health becomes not just stronger, but more sustainable for the future. This is progress we can see. This is progress we can measure. And this is progress you should be deeply proud of. Every resident in your 5 communities deserves a public health system capable of protecting them. And thanks to the members of the PN5, we're closer every day to making that vision a reality. Thank you for all that you're doing and for all that we will continue to accomplish together.
Thank you for having me. Thank you to the Brockton Health Department for hosting this symposium, and to the regional shared service partners in Plymouth and Norfolk counties, the towns of Abington, Avon, Brockton, Stoughton, and Whitman. I am so incredibly grateful to be a part, oh thank you, people maybe can't quite hear me. I am so grateful to be a part of this conversation today at this really, truly critical moment in public health. It's a moment that demands clarity, collaboration, and resolve. It's a moment that is both important and urgent. Today you're sharing community health needs assessment data that reflect real experiences and the real lives of people in this region, where they thrive, where they struggle, and where our systems fall short all too often. These data tell a story about gaps, barriers, but they also tell a story about opportunities, and I know that that's where the attention is shifting with the community health improvement plans. But they're really telling a story about people. And they tell a story about strengths. They tell a story about committed local leaders. That's what I saw when I read that report a couple of weeks ago. Engaged residents and innovative public health work that is already underway here in these communities in collaboration with healthcare providers. The data that you're sharing today and that you're discussing today really reaffirms a fundamental truth in public health, that health outcomes are shaped far more by the conditions in which people live than they are by the care they receive when they get sick. I mean, sure, medical care matters. I'm a primary care doctor, so of course I have to believe that and say that, or I wouldn't be doing what I'm doing in the clinic. That is, if it's accessible. But it really only accounts for a fraction of health outcomes. The rest is determined by all the other things that we're talking about today, in addition to healthcare access, housing stability, food access, education, transportation, environmental exposures, income, and fundamentally the safety and the cohesiveness of the communities in which we are all living our lives. These are the social determinants of health. And when the conditions are strong, health can thrive. And when they are fragile, illness often follows. And of course, because these social determinants of health are not distributed equally in society, health outcomes are also not distributed equally. The disparities that we see in chronic disease, mental health, maternal health, and life expectancy are not random. They reflect structural inequities that are built, that we built as a society, and that have persisted for generations. And the community health improvement plans that you all be shifting your attention to are efforts to interrupt that built system and to rebuild it in a new way, as you all have been doing in this area for a long, long time. The inequities that we see are the result of systems that have not treated all communities fairly or justly. And addressing these inequities requires the kind of collaborative cross-sector partnership that I see in this entire room. We have to recognize these troubling injustices that are inherent in our society. We have to call them out, study them, and address them head on. That's what the community health needs assessment enables us to do. Equity cannot be a side issue in public health. It cannot become a piece of the conversation that is rendered silent or implied. Equity is the work of public health, and it always has been. The most urgent challenge that's reflected in the community health needs assessment, and it's one that really kind of strikes close to my heart and is felt really deeply in this region, is access to care. Not surprising, right? And this area is not unique in Massachusetts, and it's not unique in the country, and identifying that as a key public health challenge. Getting health care today is complicated, it's incredibly frustrating, and it is super confusing. Massachusetts, like virtually every other state, is grappling with really significant shortages of primary care and psychiatrists, and we have a struggling workforce, long waits for new patient appointments, and pressures that are pushing providers out of practice. I'll tell a story from my own primary care practice in Chelsea, Mass. In a span of about 18 months, we lost about 4 providers, doctors and nurse practitioners. They cared for a quarter of our patients. For several years, as we tried to rebuild that gap and fill that gap, we had about 5,000 people who lost their primary care doctor. 5,000 people. In a study of 15 major U.S. metropolitan areas, Boston ranked second, the greater Boston area ranked second for the longest wait time for routine physical. These are the challenges that are reflected in your community health needs assessment when the community identifies access to care as its number one issue. But they're just a piece of that access challenge process. Our system is clearly under strain, and we understand that finding care is a struggle for people and families every single day. I see this, I live this, and of course I feel it in my own practice as a primary care doctor in Chelsea. We're getting my patients the care they need discarded every single day. And really importantly, and why we're here today having this conversation, is that this is not just a conversation about healthcare. Access is not just about having appointments that are available. It's also about getting there, getting off of work, and not having to choose between paying for your medication and paying for the roof over your head or the food in your refrigerator. At the Massachusetts Department of Public Health, we're working to respond to these issues, as you all are as well. We've created, from a healthcare workforce perspective, we've created new licensure pathways for primary care physicians and psychiatrists. And we partner with the Mass League of Community Health Centers, a fabulous partner, to offer loan repayment and incentive programs to specifically recruit clinicians of all discipline types into primary care and behavioral health fields. And these efforts really do matter. We need that workforce. We can't solve this problem without them, but they're only part of the longer-term solution. Here in this region, hospital closures have also intensified the problem of healthcare access. When a hospital closes, communities don't just lose beds, right? They lose these trusted and long-standing entry points to care, specialty referrals, and also local jobs, getting to some of the employment challenges that were raised in the community health needs assessment. And the effects of hospital closure ripple outwards. They increase travel times, crowd remaining healthcare facilities, both hospitals and outpatient. And they create significant barriers for those with limited transportation in particular, which we know is a challenge in this particular region given limited public transit. Creates problems not just for folks who have particular transportation needs, but also folks with inflexible work schedules or complex health needs. Beyond physician shortages and closed hospitals, we also see the impact of pharmacy closures on many communities in the state, including this one. Losing a neighborhood pharmacy reduces the obvious things, right? Access to medications. But it also impacts access to vaccines, and it impacts access to just sort of everyday health guidance. What should I use my Tylenol for? How much Tylenol can I take? Community pharmacists are a really important part of people getting the health guidance that they need every day. Pharmacies are often some of the most accessible healthcare sites in a community, and so when we lose them, that gap is felt immediately. The data from the Community Health Needs Assessment also point to important trends in maternal and infant health. While the preterm birth rates and infant mortality rates in Plymouth and Norfolk counties remain relatively low, which is wonderful, and a thing to celebrate. Pregnant people in this region, as was covered earlier, are also more likely to experience delays in getting prenatal care. And that matters, of course, we know, because early, consistent prenatal care is one of the strongest predictors of healthy births, healthy parents, and long-term child health. These delays in prenatal care access may be caused by clinic capacity and provider availability, and of course, I can't say that that's not a factor, it is a factor. But they're also driven or aggravated by this other social determinants of health that we're talking about today. Transportation, insurance barriers, affordability that's connected to that, language access, and increasingly, unfortunately, for folks who are living in our communities who are born outside of the United States, fear. It's not enough for these appointments to exist. People have to be able to get to them. These are, for the most part, solvable problems, but they will only be solved if we address them and see them as urgent. The Community Health Needs Assessment, of course, also underscores the impact of a range of social determinants of health on the health of communities in this region. Food insecurity, economic stability, housing, and environmental conditions, as well as transportation. I focus so far on the issues that present challenges to the health, safety, and well-being of our communities. But it's equally important to highlight what is working, and I want to take this opportunity to really celebrate a recent initiative that is just so fabulous. I love it. It's one of these initiatives that makes all of us working in public health and protecting the folks that we live around incredibly happy. And that is the Brockton Vaccination Initiative in public schools. So Brockton recently launched a vaccination initiative in partnership with Brockton Public Schools to provide childhood vaccines directly to students who aren't up to date with them. This program, which represents nearly a year of planning and collaboration, held its first clinic just a few weeks ago. And this initiative matters because hundreds of school children in Brockton had been identified as not being up to date with their vaccinations. And that troubling statistic, the data that drives action, that troubling statistic became a call to action. By bringing vaccines directly into schools, Brockton is reducing or even eliminating many of the barriers to vaccination. The things we keep talking about: transportation, time off of work, cost, and access. Brockton is meeting families where they are. And that is what modern public health, community-centered practice looks like in action. This initiative is a model of what it means to move from data to action, to move from the kind of data that we were talking about in the first half of our afternoon session today to the planning process that will be shared with you early next week. Oh my gosh, that's amazing. I have a soundtrack. All right, fantastic. And as many of you know, right now, towns in South Carolina are currently straining to contain a measles outbreak that has affected hundreds of people. It has sickened over 100 people, and there are over 250 that have been quarantined, that are missing school, that are missing work. for whom it's impacting their ability to care for the other loved ones that they have in their lives. The tinder for that outbreak, as it has been in many other states, was schools with vaccination rates lower than the 95% threshold required to keep communities safe from measles. Schools were the spark that caught fire that fueled the outbreak in South Carolina, as they have been in other places. And the initiative that you all have embarked on here locally says not here, never here. Not here, never here. As everyone in this room knows, we're doing this work at a time when public health is under extraordinary pressure, even under attack, some might say. Across the country, we're seeing decisions that appear to be totally divorced, completely divorced from evidence, from science, from data, from prevention, and from long-term impact or any consideration of what the consequences will be on communities. We're seeing increased misinformation coming from federal sources that had until recently been considered the gold standard for sound public health advice. And perhaps most concerning, and this is not unique to this federal administration, this has been going on for a while, we're seeing an overall erosion in trust in science, public health, and even healthcare providers. I also recognize that many of you in this room work directly in public health, and I want to say emphatically that your work matters. It matters a lot. It matters a ton. I get energy from being in this room with you all. Every clinic you support, every screening you run, every child you vaccinate, and every barrier that you individually and you collectively lower changes the trajectory of someone's life. I'm saying the obvious, but I think, especially right now, we kind of can't say it to each other enough. Here in Massachusetts, we will continue to be guided by the science, grounded in equity, and committed to protecting access to care. We will support your communities as you innovate, lead, and continue to act. And I promise you that the Massachusetts Department of Public Health remains committed to health equity. It's not optional, it's not negotiable, it is deeply baked in to the core science of public health. Equity is the work of public health. The gaps and the barriers that we're all talking about today are real, but they represent only one chapter of the larger story. The full unabridged version of this region's narrative is also about its people, its strengths, its partnerships, and its possibilities, and how to keep moving down that pathway towards progress, as we're talking about today and holding each other accountable for, towards this goal of building something that is stronger, better, and more fair and equitable. The community health assessment provides a roadmap, but the partnerships among the stakeholders in this room provide the foundation, and the commitment of the rest of everybody in this room and the others who care deeply about your communities provide the strength to take this journey, which will not always be an easy journey, and I know has not always been to date. Thank you for the work that you do every day and for your absolutely unshakable commitment to the health of these communities, your towns, this region, and to our Commonwealth. And thank you so much for letting me be a part of this conversation today.
I'll do it super fast. I'm representing Brockton Neighborhood Health Center, and we are the one of the largest community health centers in Massachusetts. We serve almost 40,000 patients. We're the only community health center in Brockton, and we serve, we serve all of the municipalities that are part of this PN5. Right? This is a little bit about us, our mission statement. The more important thing is to see us in the photograph, which is that we are a health center with a lot of hard work that we do, but also a lot of joy and love that we bring to our work and commitment. The values that we stand by are here. I'm not going to name them. I will highlight that we were incorporated in 1992, and we started in a van in a parking lot, part-time, like I don't remember, but about 8 hours a week. And we have grown to 5 clinical sites, I think a total of 7 sites. And as I said, almost 40,000 patients, over 215,000 visits a year, and a staff of almost 600 individuals. These are our clinical locations. Our main site, otherwise known as the mothership, at 63 Main Street. Our Pleasant Street location, which is pediatrics. Manley Street location is our clinic within a homeless shelter with a partnership with Father Builds in Mainspring. A mobile unit that is primarily serving those who live on the street or are struggling with homelessness, and a small developing school-based health center. And I do want to point out that this is what I was kind of come up to say if I didn't present, is that while there is, we certainly feel, and I think the Public Health, the Board of Health feels it, and the healthcare industry is feeling it, a lot of pressures that have been named around access, soon to be around health insurance coverage and access to Medicaid in the context of the big beautiful bill. Commentary to the side. But I will say that, you know, we are so committed to trying to create access that we do currently have access for primary care. So to all of the agencies that are in the community, we currently have access to primary care. And we as the team feel committed, but I, Maria Celli, feel very committed to trying to serve as many people in the community as possible. When we speak about primary care, we're talking about, you know, primary medical care, but also access to community health workers, access to behavioral health as an integrated and essential part of your primary care. And I say that because we also saw in our own population the concerns around youth mental health. It's, you know, I feel affirmed when I see it in the CHA, the community health assessment, but we saw it in our own patients, and we invested in programming for youth mental health within the clinic and at the school and at the high school. We heard about the vaccination gap at the high school and are trying to build out a sustainable medical program, primary care program for the high school as well. We saw the need around maternal health access, and we have applied for grant funding and have numerous grant programs and initiatives that are running within our OBGYN department to provide equitable access to maternal health care, and as well as the data to help us to evaluate our own progress. So we want to be a part of the larger ecosystem collaborations, even with the other municipalities, to move that work plan forward. I think Dr. Montesier knows that, but say it out loud. Just whizzing by here, I won't get into all of this because, but you can see, you know, over 60% of our patients are from Brockton. Over 70% of our patients are covered by Medicaid or are underinsured and covered by the health safety net. So this is an area of great concern for us coming up, as some people may lose Medicaid eligibility, and BNHC is getting ready for that, but I think that is a major threat that was not reflected in the CHA, because at the time that the key informant interviews were being taken, that wasn't such a threat that we would know would be coming. I think we should be ready for that as a community. And I know BNHC is doing it, and I know separate agencies are doing it, but I think we should come together and address it the way we did COVID, in a way. Something about our patient demographics, I do want to just point out, as I said, some of our core services: primary care services, OBGYN, endocrinology, neuropsychiatry, and some remote cardiology consultation. Substance use services is part of our core services, behavioral health, dental, infectious diseases, eye services, a thriving pharmacy, and nutrition services. So some of you know us really well, but if you haven't seen BNHC ever before or would be interested in coming by to visit, please see me at the end or see the amazing BNHC team at the back. And you could stop by and pay a visit and get to know us. We have a lot of services, and we're really proud about them. Another need that had arisen in the CHA and that we had seen in our own workforce and in the community was need for future primary care providers. You know, who are the Dr. Zeidmans of the future? Who are the Dr. Lawsons of the future, and the Maria Cellis and all of the staff at the health center? And so we started to invest in workforce development within our own staff, and then we built those pathways out even into high schools in the region. So we have a program Thanks to the generous funding of the HRS Health Equity Foundation, we built a program with the Brockton High School called the Hometown Healthcare Academy. I don't know if anybody's here from HHA, but it's an excellent program. Marlene Amidy's here from Haitian Community Partners, who we partner with, and Moises Rodriguez, representing still the Cape Verdean Association. Okay, so we work with the Cape Verdean Association, the Brockton High School, and we're trying to develop future healthcare providers from the high school, and that can work at BNHC, that could work at the local hospitals. But we're really trying to invest in workforce development through partnerships and even within our own staff. So I guess I want to say that there has been, and I mean, these are some of the system challenges that we've been dealing with, COVID, all sorts of disruptions, but I think even with all of that stress, there is hope, and I think some of that hope comes in the collaboration that I know is possible in the city. I've seen it, I've worked it, and BNHC is here to do it again.
I believe the slides too much, but I thought it would be time to reintroduce the hospital. Our hospital's been through a rather chaotic 5 or 6 years, and I thought I'd bring that here because we are one of your partners. In the overall scope of healthcare, being a hospital, we're probably a very small partner, but I think a critical access need in the community. And listening to everyone here today, it makes me reflect on just how close and how fragile our healthcare system is. Even in Massachusetts, even with, we've got some of the best hospitals in the world around us, but it's still, it's a narrow margin that we ride along in. So, who are we? So we are compassionate community-centered care. We are a fairly good-sized, fairly large community hospital, and we want to stay exactly that. We are not trying to become a tertiary center. We just want to provide the best care in the community, keeping patients in the community that are appropriate as we go forward. We're chronic disease, heart disease, obesity, diabetes, etc. We have a very robust emergency department. With that, we're a level 3 trauma center, we're a cardiac care center, we're a stroke center. We do deliveries, we have a level 2 nursery. All of these things have been running for quite a while under the name of Good Samaritan Medical Center under Stewart Healthcare, which is usually followed by a chorus of boos or something like that. Well deserved, don't quote me. But we've come out from all that. Right now, even through the tough years that we've had, the service that's been given by the team there, the staff there, has been really exemplary. Of all of these things that are current awards and recognitions, I really like the Patient Safety Excellence Award. It's the top 5% in the country, and it's purely measurable metrics going out. So it's a nice thing to have for that. But I think it's credit to the team that works there, and I'm hoping that it gives people a sense of a little bit of confidence and trust when your patients come into us as we move forward. A little bit of the timeline of the hospital, and I'm not going to go through all this, but just for fun, I happened to notice that back in 1959, you could build an entire hospital for $1.4 million. Right now, it's about 80 times that to build a hospital, which may be why there's not a lot of hospitals going in right now. But if we fast forward on this, you'll see under Stewart, okay, I didn't do that. All right. So if you look at the last few years, so I was an emergency medicine chief of a fairly good-sized emergency department in Brockton, and shifted over just in time for all the fun to happen here. So I came into a brand new emergency department that Dr. Herman put in, thankfully, for that, but moved over to Good Samaritan Hospital right after it achieved its trauma center designation. It's the first trauma center in all of Region 5, a huge chunk of Massachusetts and desperately needed. for services. But as we go forward, it's showing how tenuous healthcare is. So less than a year into it, we have COVID. And everyone has tales of COVID, but just for our community here, we got our first COVID case. 2 weeks later, we had 236 inpatients with COVID, 40 intubated patients, and 75 deaths in our community. It was hit very hard, very fast. Some of the unique reasons why are all the things we've spoken about with that. But that took every single bed and 40 extra beds for the entire hospital. So what do you do with your heart attacks and strokes and everything else that goes on? So we're merrily going along, and we all get through COVID, through a lot of resilience, etc. In July, Norwood Hospital closed. They had a water main break. I remember getting the call, because I was the administrator on call for the region, and they said they had a leak. And like the next statement was, there's divers in the basement trying to find the source. So the entire hospital shut down in hours. A credit to everyone in the region. They got everyone out. Everyone was safe. No one was killed in the event. So now we have one acute care hospital taken offline, and with that, 61 behavioral health beds. We do not have enough behavioral health beds in Massachusetts. We know that. As we go forward, we're in part of Stewart. Stewart's gradually heading into bankruptcy during this time period, and we get into this period where Brockton has a fire. So another hospital closes within hours. They're able to evacuate the hospital, and a credit to everyone in this entire region that no one was killed. Huge with that. But we all talk about the day when all patients were moved out of the hospital. To me, being in the business, that's the smallest part of that emergency. It was the next 18 months when we did not have enough beds in the region. And every single day, the surrounding hospitals were in a state of emergency. So that was Brockton Hospital. We were still Good Sam at that time. And then later in the year, in June, Compass Medical closes. So now we're starting to talk about, we've got a financial thing with Stewart, which is a whole wonderful discussion. It could be a lecture series on private equity and money and greed, and who knows, again, don't quote me. And then we get to Compass Medical closing overnight, and all these patients need to have access. So another stress on the system, and we don't have excess capacity here. We get to May of 24, Stewart Healthcare declares bankruptcy. Talk about a damage to trust in the healthcare system. And the state is faced with all of these hospitals that potentially could go under. Are they going to be sold? Do they need to be closed? A lot of major decisions have to be made. And very quickly during that time period, a lot of credit to the state for helping in this process in Boston Medical Center. But that was sort of the bottom of all of these things going on. We were acquired by Boston Medical Center, which I think was a fantastic match. And since then, we've been going vertical. We've been strengthening the system in the region since then. So big credit for that. As we go forward now, we are Boston Medical Center South. Good Sam is gone, Stewart is gone. With that, and we're sticking with that. There's Boston Medical Center, we call it Maine. There's Boston Medical Center Brighton, which used to be St. Elizabeth's, and our hospital, Boston Medical Center South. So, continued dedication, we are going to continue to grow with that. What's nice for this is Boston Medical Center is a large healthcare entity and now healthcare system. And they have all these other things which I don't think anyone in our area knew everything that's on this list. You sort of know some of them. But just looking up there, you can see the medical center being formed. It used to be City Hospital, my alma mater. With that, forming with Boston University Medical School, the medical group. For there, they have 700 plus attendings. In the medical group, to give you an idea, our medical staff is about 700 as well at Boston Medical Center South. Moving down, so you've got the healthcare networks, they've got the facilities that they cover. WellSense is something also run by the health system, has 700,000 covered lives in it, so pretty impressive. BACO, when you keep going down the line, a pharmacy network. And then the most important thing is that they acquired Good Samaritan Medical Center, became South with that. So I like the exceptional care without exception. That's a nice thing. It means a lot. Respect powered by empathy, moving mountains, and what a wonderful statement. Many faces create our greatness. Okay, and I think that's real. I think it's a really good match of Boston Medical Center and Good Sam to make Boston Medical Center South. I mean, you can't go wrong with that. I think we have very, very much aligned interests as we go forward. Not that good framework. So what are we doing? As we move forward, the highlight here is access to care and equity, enhanced care for more patients, rebuilding primary care, enhancing access to specialty services, all the things that we need, all the things that we've been speaking about. There's a very concerted interest in growing here. Under the prior owner, the hospital was unable to grow because no money was being reinvested in it when it desperately needed to be reinvested. So little things like we have a 3D tomo for mammography. If you look back on our slides, that is a critical access right now. We do not have enough mammogram capabilities in the region. Adding machines for that. We just added 11 radiologists to read mammograms. Huge. We're trying to catch up because we're years behind in the region with that. As we continue to grow with this, we have just implemented EPIC. EPIC is a healthcare record system which is immensely complicated. It's very intricate. It's in everything, but it allows us access to records all over the country, and right now, pretty much all over the world. So it's better healthcare for your patients. Think about it, in today's world, that's a $100 million investment in healthcare for the 2 hospitals to be added to Boston Medical Center's system. So there's really a lot being put for our growth going forward, things that we need. So I think these are really positive things. And again, I'm hoping people stop using the term Good Sam. It's hard, it's built in. But we want this to be Boston Medical Center South, and understanding that we take very seriously that we are a partner as we move forward. And we're hoping to really align everything with Boston Medical Center. We work well with the state. We can't thank them enough. We wouldn't be here in this capacity if the state hadn't intervened for that. So please spread the word with that. But we have a bright future together, and we desperately need to keep places like this going and growing with that. Luckily, Brockton Hospital reopened. We need 2 hospitals in this region. We don't have enough inpatient beds to handle the volume with that. One of the things I forgot to mention on that, just thinking of expansion and doing the right thing, Boston Medical Center opened up a behavioral health hospital here in Brockton. 106 beds. That's huge. That's we are all part of that. I think you've got a lot of people sort of leaning in at the right time. Everyone's for the same purpose as we go forward, and just wanted to reintroduce our hospital.
I'm going to keep this very brief because I think that there is a significant role that faith communities play in public health. We can go all the way back to scripture and consider what the book of Leviticus says about how to treat people with all kinds of diseases and how to quarantine and how many days to inspect. And if you see this sign or the other sign, this is what you are supposed to do. And it's all written. If you have the leisure to do that scientifically, spend time and read Leviticus chapter 13. It gives you a laid out plan. So when faith communities are ignorant, which happens sometimes, especially during a pandemic, we end up struggling to help people to understand that when we are asking people not to come to church, which they think is a do or die issue, that there is a biblical reason why we need to show love for our neighbors, but ensure that we ourselves are very well. I think that we learned a lot during the COVID period in this community. Dr. Mondesir really championed a team of getting people who are religious communities in the is going to be on their record, and for the rest of their life they're going to be labeled this. So I'm not going to take them to the hospital. I just want you to come and pray over them, and then things will be okay. And don't get me wrong, I believe in the power of prayer, but I also believe in the power of medical science. That you can encourage people because they have trust in you. You can say, let's go do this. I will walk with you. I will come with you to the mental health professional. I assure you it's all going to be okay. That gives them a little relief to say, well, I ran it by my clergy and they said it's good, so I'm going to go for it. Or some of the stigmas that goes with sexually transmitted diseases and how people assume it's because they had done something wrong, that God is punishing them, and therefore they don't want to go and tell somebody else. Not only is it about the disease, but also about the moral situation they feel. So you have to talk with them and convince them that God is a bigger picture, and I'm not sure that that one that you're worried about is God's concern with you right now. If you're not alive, you are useless to anybody. So there is a relationship of trust that I believe contributes to enabling people to actually take that step. I can't tell you how many times I have walked with somebody to a medical appointment because they were uncomfortable going by themselves. Or how many times I've held somebody's hand and prayed with them as they were rolled in for surgery because they felt it was something that would actually transform their lives and make it maybe more acceptable. It's interesting that I'm sitting here, I have two people in hospital, I'm texting them to see how they are doing because they need to know that their clergy person is with them. And they need to know there's a whole faith community that's watching over them. So they feel comfortable going in to the hospitals to say, I have this certain needs, some of which, if not addressed, may actually impact their neighbors and other people. Let me say one other thing. Those of us who are in spiritual leadership find it necessary to model for the people at the church certain behaviors. And we are not good at doing it, truth be told. During COVID, I know I preached a lot about people, the need to go and get your vaccines. I preached a lot about, I actually found sermons from 1918, 1919 about the Spanish flu to kind of make the case for it. And then I remember one day sitting with people and they are older and more vulnerable. So why have you gotten your vaccine? Not yet, or what? And somebody said to me, Pastor, have you gotten your vaccine? And I said, well, not yet. And it's like, oh. I called Dr. Mondesir, we arranged, and the church became a vaccination spa. So we got people to come in. People who were scared, people who had been told that the vaccine was not something to believe in and that it was going to cause God knows what. And their pastor has told them about it, but I was first in line so they could see that as a model that I believe in vaccination. I'm from Africa. No vaccine, no life. I can tell you this. I hear all this argument about vaccine, and I'm standing alive today because of many of the vaccinations that I got when I was a child. And so I felt comfortable doing that. But we have to be models, not just telling people what to do, but actually being at the forefront. And so it was easy when I went for my booster and everything. It was a lot easier to convince people the second time around because they already knew. And one last thing, churches and religious communities have facilities that are useful. I just mentioned the vaccination with them. The church has a space. So we can create that atmosphere, encourage people to come over and participate, because you don't have to go rent space somewhere else or find a location somewhere else, but we can do that at that space. So I think partially it has worked in my relationship with Dr. Mondesir because I know him. I don't know if it's somebody else, how that might have worked out, but certainly personal interaction. This kind of events, I'm here with a fractured foot, but somebody said that if they are partners, but you're the one who said you're usually not working on Fridays. But, all right. All right. I mean, if Dr. Montesir calls, I show up.
Why is this important? It's because perhaps you asked the question, who is taking care of the caretaker? Because the rest of us, that's what we do. We take care of people. There is what we do and there is who we are as well. I am a pastor. My church is in Boston. I am the assistant pastor at Tabernacle Baptist Congregation. And it's one of the largest Haitian church in the community. But also we have this challenge that comes to us every day. And it started becoming even harder with the political climate that we are dealing with today. I work at Yves, that's Immigrant Family Services Institute. I am the director of something called Building Alliance to Support Immigrant Mental Health. This, a long time ago, when I started teaching at Gordon Conwell Theological Seminary, I started back in 2004, but in 2008, I was responsible for the counseling department at CUNE in Warren Street in Roxbury. We were using DSM-3, DSM-4. At that time, when we diagnosed someone, typically we don't know exactly what is the most fit diagnosis. We go with N or S, not otherwise specified. So when the DSM-5 comes around, they eliminate that. But as we speak today, it seems to be a new category that needs to be added because in your community, you have what is known as immigrant mental health. And that is going to be a very serious thing. Because these days, you diagnose somebody with something, then you find out, that's not it. The client tells you it's not the problem. When you thought it was this, you talk about adjustment disorder. It's not that. You talk about this type of problem. This young kid come to you and tell you that he has this and that. You think he's been abused or she's been abused, neglected and everything. Then you find out, that's not it. So the question is, what is it? Well, it's immigrant mental health. It's a different view, it's a different thing that a group of people come in the community and they come with themselves. They are cultured people, and they bring their culture with them. And of course, everything that we are affected with in society, they've been affected with all of them. And then also they happen to be displaced people. And in the process of being displaced, moving from one place to another, they carry all this burden with them. Sometimes we go with trauma, then we realize, no, it's not really trauma. Then the question again goes back where it is. Sometimes the rest of us, we feel like we are incompetent because we don't really know what we are dealing with. Because the problem that the immigrant mental health is going to bring to the community is yet to be diagnosed and be considered. The schools, we realize many diagnoses that are coming to us. Children with 2, 3 years old, they come with a diagnosis, autism, diagnosis with ADHD, 3 years old, diagnosis with social disorder. This kid doesn't know and respect other people's right because he's only 2 and he says no and he can spell it for you. And you understand that there is a serious problem that even the school doesn't know yet what to do. The teenagers, they're going to have issues. And those issues are issues basically that are going to mount up. They're going to sums up. And the community has to really embrace that and know what to do. Well, the other thing that I just told you that I'm a pastor, so we have the question as well, who's dealing with these things, with these problems? It's not just the local community. At Yves, you name it, we have faced it. We have to deal with all that. And yes, the confusion is still there. We try to see if we can understand the culture. We try to be culturally competent. We try to do culturally responsive intervention. We do all that, but at the end, we realize one other thing. There is a problem that comes to us, it's also spiritual. It's not psychological. it is psycho-spiritual. But it takes a special someone to really understand what seems to be going on. You need to have a theological competence to understand doctrine, to understand church, to understand living in community, to understand what it means to be a person of faith. And then at the same time, to try to understand when is it a psychological disorder? What do you do with it when it comes? And how do you address it? And we began to have some distress on our part as providers. We do not have the resources to support them. Many of the groups that exist in the community or in the church, they don't have the resources. They don't have the money. They cannot pay someone to sit there and to address these problems when they come. And they come every day. We have, among the immigrants, people who come, they don't trust the psychologist. They don't trust the school. They don't trust the police department. They don't trust anybody. But they do trust their pastor. They do trust a family member. They do trust somebody that can take them and carry them to the next level. We come to realize that depression is something that is relational. You have one person here who is depressed, mom is depressed, the child is also depressed. The behavior that you see is a reflection of what he or she is dealing at home. So the depression is coming right from home. So how do we go about addressing it? So Yves put forth a symposium that brought out the task force. And the task force had to answer a few questions and a series of things that we have in our community that we have to deal with. It's the problem that every one of us we are dealing with, that we don't have enough resources. There is no money to pay somebody to do things, or we have to deal with something called the insurance company. The insurance is a serious problem. They want diagnosis, and just like I told you, there is a diagnosis that is called immigrant mental health. That is not in the DSM. It used to be NOS. It's no longer. They don't pay for NOS, not otherwise specified. They don't pay for that. You have to give a diagnosis. And sometimes when you go, then you say, okay, what do you do in order to make sure that this person who's desperately need the assistance, in order that they may have the assistance. You have community ministries. My wife leads a ministry that is known as the Sentinels. We go directly where the problem exists. We sit down with a sister, with a brother who's dealing with a problem that he could not sleep over last night. It's just a problem for one period of time, but he just needs assistance. And if you intervene at the right time, the right moment, you can stop a disaster. Literally true. You just have to be there. Well, we realize that there is something called ministerial presence. And that's what the rest of us clergies, we do. Sometimes we receive a phone call at 1 o'clock. Now, if you call in Dr. Celestin at 1 o'clock, I should call the mayor's office, don't you think? Instead of 911. So you should call the mayor, not me. But the pastor, they call you anytime. Sometimes they come with the problem. You hear the bell, and then you say, ooh, at that time, then you find out, okay, they bring the problem to your doorpost, and you have to address it. Then the task force at FC really asked the question, what then shall we do in order to really create this sense of urgency in the part of the policymakers, for them to be sensitive, to realize that the money that they're going to spend, as they're going to make the budget for the next fiscal year, how they're going to make sure that there is equity in the way that the money is spread in order to have enough workers. We are doing a very good thing these days on creating what is known as community social workers. It's very good, but that's what they are, community social workers. We also need psychotherapists. We need the counselors. We need people who can go deeper in the matters, people who can sit and understand how the mind functions, and to answer the question, why do you do what you do? And as a result of what you do, how do we go about modifying your behavior? Just like I mentioned, the young kids. Whatever mom is going through, this child is going through the same thing. Whatever dad is going through. And as you know, many times among the immigrants, there is no dad. So these people come, and they are part of the community. I said to a good friend who happened to be a deputy in one of the police station, he made a comment, and I said, well, we have to find a way to know what we're going to do because these people are not going anywhere. Now, I don't want to be political, okay? But they're not going anywhere, you understand? They are in the community. You have to understand that they're part of the community, and whatever decision you're going to make, you have to consider them. That's where the church comes. These folks come to church every Sunday. Every weekend, we have them. We deal with them as well. So what we are saying is that as you are making decisions to serve, you also need to have a holistic approach. We call it eclectic. Look at everything, because everything matters. Sometimes you think that's not it, maybe it is, or maybe it's not really, but it is the only step that if you take it, then you solve a lot of problems.
And thank you very much for the question. So as a public health physician, I want to add a few things. So in public health, for example, in the study we presented earlier on, the community health assessment, if you scan the code and you download that document, you will see that primarily our assessment was driven in from two angles. From an angle of what we call social determinants of health, and then the health outcomes. So why do we want to look at social determinants of health? We look at those social determinants of health from an angle and intention of prevention, because we know that these are the drivers of the morbidities that we see on the other end. For example, you see obesity, you see alcoholism, you see as unfavorable health outcomes, you see youth mental health deterioration as unfavorable outcomes. But when you look at the drivers, then you now begin to consider the issues of homelessness, the issues of substance abuse, the issues of the social adolescence health, let me just put it that way, the social and psychological ambience in which our children are growing up. Is that ambience promoting a culture of violence? Is that ambience promoting a culture of self-stigma, for example? If it is promoting any of these two, it will definitely lead to an outcome that will not be healthy. If it's promoting a culture of violence, then you see an increase in violent behavior. If it's promoting a culture of stigma, you see an increase in depression. So, on the other hand, also, we look at issues of homelessness and housing. Homelessness and housing will drive overcrowding, for example, there are many studies that show you children who grew up in an overcrowded environment, which some want to call a slum, or let's avoid that word, they tend to be higher incidence of violence. So there are some things that you cannot really address from a public health perspective without looking at the social determinants of health, because you want a perception, you want a clear perspective of what is driving these unfortunate health outcomes so that you can nip it in the bud. And that is basically what we call prevention. So if you look at that study, it might not have used that word directly, but of course you look at it, you see that the understanding is we're looking for the drivers of the unfavorable health outcomes with the intention of mitigating those drivers so that the unfavorable health outcomes will be controlled, which basically is for prevention.
But I honestly just want to thank again everybody that's here on behalf of our city, on behalf of our current mayor, on behalf of the current city councilors and school committee members, on behalf of those that are coming in January. We truly, truly, truly appreciate the work that's done by all of you and all the agencies that were here. Brockton, when you sit down and think about it, we are the mecca of medicine south of Boston. When you look at, this is where all the hospitals are, this is where the best health center in the country is at. And Maria, I'll expect that check. But it truly is. I mean, you've got great churches, great community organizations, great hospitals, a great health center, and many, 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 many health providing individuals in this community. So I think the only thing that I would say is perhaps next time that we're doing this, let's not do it on a Friday. And perhaps not in the afternoon as well. Maybe do something in the middle of the day so some folks can actually come, because I think this was a worthwhile undertaking in the sense. So, but again, I just
No taken, Mayor.
you got it? All right. So I just want to leave it here that, you know, this is a great city. We have our little problems like every other city has. The diversity in this city is something that I think Boston needs to look and take us a little more serious. Where's that Deputy Commissioner? She's over there? Okay. She's acting like she's not listening. You know how those people are. But we need, yeah, absolutely. But we need, you know, Boston to take us and take our needs a little more serious. And when I say Boston, I'm talking about state government. Because of the necessities that this community has, the fact that we have the largest of a lot of things in this community. This is the most diversified city in the Commonwealth. As a matter of fact, we're the only majority black community in the entire New England states. So that alone should tell us some of the health disparities that exist out there, that we need to take this city a little more serious and put resources behind it as well to help us help our citizens. I remember what happened in COVID. We struggled here because our community just was not as informed as some of these other communities. I think for the longest time, we were the second worst community in Massachusetts in terms of infections. I think somebody actually told me not too long ago, I think it was Yves, that mentions that the Cape Verdean community is one of the highest communities when it comes to opioid overdoses and death in the entire Commonwealth in the sense. So that those are things that are, and I keep saying that we have things provided in a variety of different languages and stuff, but some of these other mega communities that we have are often forgotten. So we need to kind of make sure we put the resources in the right place so we can provide the services that our community truly, truly deserves. But again, I didn't come here to gripe. I'll do that after January 5th. I just wanted to, again, just thank you guys all for being here, for doing the work that you did throughout the periods and the work that you'll be doing going forward. So thank you, and please continue to believe in Brockton, and please continue to provide the services that you guys provide in our community. Thank you.